Good afternoon, everyone. My name is Safwan, and today I'll be discussing our findings of favorable waitlist outcomes in patients with alcoholic liver disease in the MEL sodium era. My co-authors and I have no conflicts of interest to disclose. With the introduction of curative hepatitis C therapies, alcohol is now the major reason for listing and transplantation for liver diseases. This is depicted in the following figures generated from the UNOS database. A unique aspect is that, compared to other disease etiologies, alcoholics are often required to be abstinent for a period of time prior to being listed. This may reduce disease progression while on the waitlist and therefore alter their waitlist outcomes compared to other disease etiologies wherein the causative factor still persists. Hence, our aim was to evaluate discrepancies in waitlist outcomes between those with alcoholic liver disease and non-alcoholic liver diseases. Data was obtained from the UNOS registry. All adult candidates waitlisted for liver transplantation from Jan 1st, 2016, which was when the MEL sodium system was introduced, to May 30th, 2018 were selected. The patients were divided based on liver disease etiology, and the four major etiologies, alcohol, NASH, hepatitis C, and cholestatic diseases, were studied. The exclusion criteria included age less than 18 years at listing, having malignant liver tumors, having had a previous liver transplantation, and having overlapping and/or multiple liver disease etiologies. We first compared waitlist outcomes between alcoholic and non-alcoholic liver disease patients and found that the incidence of death was higher in non-alcoholic disease patients, whereas probability of transplant and recovery were lower. We then adjusted for the following risk factors, which included recipient characteristics as well as the MEL components, and performed a similar analysis comparing outcomes between the two groups. After adjusting, we observed that overall, alcohol liver disease patients had similar waitlist mortality and transplant probability, but a higher chance of recovery on waitlist compared to non-alcoholics. On examining specific MEL groups, alcoholics had similar waitlist mortality and a higher chance of recovery across all score groups. A variation was only noted in the MEL 6 to 20 group, where alcoholics had a lower transplant probability compared to the non-alcoholics. We then proceeded to analyze waitlist outcomes among alcoholics and the major non-alcoholic diseases. Overall, NASH patients had the highest mortality, whereas alcoholics had the highest transplant probability and recovery rate compared to other diseases. On adjusting for risk factors, we observed that overall, NASH and cholestatic diseases had higher waitlist mortality compared to alcoholics. All groups had similar transplant probability, whereas recovery rate was significantly lower in all non-alcoholic disease groups compared to the alcoholic groups. On examining specific MEL groups, NASH had higher mortality in the MEL 20 to 30 group, whereas cholestatic diseases had higher mortality in the high MEL group. In terms of transplant probability, all non-alcoholic groups had higher transplant probability in the low MEL group, whereas cholestatic diseases had lower probability in the high MEL group. Recovery was significantly lower in all non-alcoholic groups in the low MEL group, whereas NASH was the only condition with lower recovery in the 20 to 30 MEL group. So which group of alcoholic liver disease patients should actually be prioritized and less prioritized? To answer this question, we performed a multivariable analysis to identify risk factors associated with waitlist mortality in alcoholic disease patients. Overall, older age, life support use, lower Karnofsky, high INR, low GFR, and sodium abnormalities were associated with mortality, whereas obesity was protective. In the low MEL group, being underweight, having a low Karnofsky score, high bilirubin and INR, and a low GFR and sodium were risk factors. In the middle group, older age, low Karnofsky score, high bilirubin and INR, and low GFR were risk factors, whereas obesity was protective. And finally, in those with high MEL scores greater than 30, older age and life support use were the only risk factors. So to summarize, alcoholic liver disease patients have lower mortality, similar transplant probability, and higher recovery rate compared to non-alcoholic patients, especially in the MELD less than 30 groups. NASH, with MELD scores between 20 and 30, have higher mortality and lower chance of recovery, whereas in the high MEL group, cholestatic liver disease patients have higher mortality and lower transplant probability. These findings suggest that maybe risk stratification and prioritization of liver allocation according to liver disease etiologies might be needed. Overall, alcoholics may need to be less prioritized compared to patients with other disease etiologies, especially in the low MEL score group. In the mid-MEL group, NASH patients have the highest mortality, and in the high MEL score group, cholestatic patients have the highest. Hence, maybe prioritizing these patients might need to be considered. To conclude, alcoholic liver disease cirrhosis patients have lower waitlist mortality and better recovery on waitlist compared to other end-stage disease patients, especially in the low to mid-MEL score groups. These results suggest that risk stratification and prioritization of liver allocation may need to be altered according to the liver disease etiologies. Thank you.
So we'll just go ahead and open it to questions for Safwan.
So, how would you suggest we change the allocation policy?
Maybe based on etiology, as I mentioned, maybe in the low group, since they recover, there's a higher chance of recovery, especially in those with low MELs between 6 to 20. Maybe, I'd maybe list them later, or maybe look at risk factors, as I'd mentioned in this chart. And those who've had, lower, who have had no risk factors, maybe, wait for them. And in the mid and high groups, maybe in the mid, NASH seems to have a higher mortality compared to alcoholics. So maybe, give them prioritization. And in the high groups, which is greater than 30, maybe the cholestatic diseases.
So you would give extra points?
Maybe.
Did you separate out the alcohol hepatitis patients?
Not in this study. And there were very few. Out of maybe like over 6,000 patients, it was maybe, in the past 2 years, it was maybe close to maybe 200 patients. So.
Actually, I have one question, Safwan. The last group, the greater than 30,
Yes.
I thought it was interesting that the GFR is not indicative of that. How would you explain that?
In terms of mortality?
Yeah. Because it was in the earlier group, and you kind of expect that.
As an independent factor. After adjusting for everything else, it wasn't.
Any idea why?
Maybe numbers, because
you would expect
it was just 1,600 patients. That makes sense. Yeah, maybe. And also, it's everyone higher than 30, so they already have high MEL scores, and so they're already getting transplanted, more and sooner. So maybe they don't die. They're not waiting till they die. They're just getting transplanted before that happens. So maybe that's why we don't have. This group especially don't have a lot of people waiting.
Yeah.
Without that outcome, because it's the three outcomes where it's either they recover, they have more, they die on the list, or they're transplanted. So there's a higher chance that they might be transplanted. Hence, that factor is not an issue. Yeah. Hi. Yeah. Mm-hmm. We excluded them. Yep. Yes, it's purely just alcohol. No overlapping. They had overlapping like NASH and Hep C excluded. So if they had.
Time of duration of sobriety, and if that mattered for recovery, for example, if they were just hitting the 6-month mark of sobriety versus like those who were 2 or 3 years sober, that recovery.
Well, I'm not sure, but Dr. Nagai did mention that a lot of centers don't have like a strict sobriety period, so it's tough to have that data, and also in the UNOS data, that data isn't there for me to look at. So, yeah. But that would be interesting. Maybe center specific, looking at it. Mm-hmm.
And in presenting data to patients, to what extent is it a disincentive to the patient who is an alcoholic in terms of wanting to pursue sobriety when they're looking at the data?
So I just feel that maybe since the insult is gone in alcoholics, since they're abstinent, they don't have that causative factor that's progressing their disease compared to other diseases. So I'm not talking about those with high MEL scores. For them, yes, we should have the same allocation. It's only those who have a lower MEL score who might maybe benefit from just waiting rather than getting a transplant sooner or being listed. So.
Any other questions?
Yes. So it was just a code on UNOS. Okay. So I'm not sure how they defined it, but I would just say that maybe they were just delisted. They got better, and then the physicians would have, identified that they don't require a transplant anymore, and delisted them. So.
Okay.
Yep.
Thank you very much.
Yeah. Thank you.
Our second presenter is Dr. Elise Keynes. She'll be presenting on the predictors and outcomes of acute graft versus host disease and liver transplantation.
Good afternoon, everyone. We'll start with some background information regarding graft versus host disease, which I'll be referring to as GVHD, after liver transplantation. The first case described of GVHD after liver transplant was described in 1988. We know that GVHD is due to the engraftment of T lymphocytes associated with the donor graft that leads to a destructive cellular immune response against the recipient's tissues. The reported incidence of this condition, GVHD after liver transplant, is approximately 1 to 2%. Acute GVHD usually occurs in the 2 to 6 week period post-transplant, and we know that the prognosis is poor with greater than 85% short-term mortality. Now, most of our data regarding the risk factors for GVHD comes from case reports and limited case series, but we know that some risk factors include older age of recipient, close HLA and B matching, greater than 20-year donor to recipient age difference, a history of hepatocellular carcinoma, as well as alcoholic liver disease. We chose to study this topic for several reasons, one being the high mortality associated with GVHD. The second reason is that we noted our incidence at our center of GVHD was slightly higher than that reported in the literature, and we thought it was important to share our experience at our center as learning for for other centers with maybe similar experiences, given the limited data. The purpose of our study was to study the predictors and outcomes of GVHD after liver transplant. This was a retrospective review of patients who underwent transplant over a 4-year period, 2014 to 2018, and we identified patients with acute GVHD. Their GVHD was diagnosed based on clinical characteristics, as well as biopsies of the skin, gastrointestinal tract, and bone marrow. Many patients had short tandem repeat testing in the serum and tissue biopsies. And we used descriptive statistics to analyze risk factors and outcomes for our patients. Over that 4-year period from 2014 to 2018, 480 patients underwent liver transplant. We identified 13 patients, which was 2.7%, with acute GVHD post-transplant. Majority of patients were male, 69%, 77% were Caucasian. The mean donor-recipient age difference was 27.5 years, and the median time from transplant to the diagnosis of GVHD was 41 days. 31% of our patients had a diagnosis of hepatocellular carcinoma, 54% shared MHC class 1 alleles, and 69% shared MH2 class 2 alleles. In terms of the etiology of cirrhosis, 44% of our patients had NASH cirrhosis, 25% alcohol, 19% were hepatitis C in their etiology, and 12% had combined hep C and alcohol. The presenting symptoms in our patient cohort, the majority of patients presented with rash. The second most common presenting symptom was fever, with 62%, and 23% presented with diarrhea. Interestingly, all of our patients were lymphopenic at the time of diagnosis with an absolute lymphocyte count of less than 0.5. 54% had leukopenia, 46% were thrombocytopenic, and 92% were anemic at the time of presentation. So as mentioned earlier, short tandem repeat testing was done on serum, bone marrow, skin, and gastrointestinal tissue in our patients. If we return our attention to the figure on the left, some background information about short tandem repeats. These are short sequences of DNA, usually 2 to 5 base pairs, that are repeated about 5 to 50 times in the DNA. For a given STR, the sequence of base pairs does not change from person to person, but the number of repeats can, and this is really an inherited characteristic, and it can be used to identify an individual's DNA. The figure on the left is an example of a recipient at time of prior to transplants, STR testing on their serum. The middle row is the donor's STR in the serum, and the last row is the recipient bone marrow STR testing after transplant at the time of GVHD, acute GVHD. And what's demonstrated in the lower row is a significant chimerism, so donor STR present in the recipient's bone marrow at the time of GVH diagnosis. On the right side, this is our data for our patient cohort. The median STR rates in the bone marrow was 42%, skin 14%, gastrointestinal 11%, and blood 28%. In regards to induction for our patients, 7 patients received antithymocyte globulin, 5 patients received Simulect or basiliximab, and 1 patient received steroid-only induction. Comment on our induction protocol at this center. Prior to April of 2018, our patients, all recipients greater than 68 years of age, received Simulect for induction, and those less than 60 years of age received thymoglobulin. This protocol changed as of April 2018 for all patients receiving steroid-only induction. In terms of how we treated our patients with GVHD, all patients received IV steroids, 69% also received etanercept, and 38% of patients were treated with both etanercept and photopheresis. This figure is a list of our 13 patients in our cohort, and some basic characteristics: their age, gender, etiology of cirrhosis, their clinical presentation, treatment, and the time from transplant to GVHD diagnosis. And this figure as well specifically notes our STR data. Not all patients had STR done on all tissue samples. Just as a note, our patient 11 was the only patient who had STR testing done of the CSF, which had 49% donor in the CSF. In terms of our outcomes, the mortality in our study was 62% with a median follow-up of 115 days. Infection and multi-organ failure was the major cause of death for our patients. The median time from diagnosis to death was 33 days, and we noted that survival was associated with skin involvement on presentation, as well as negative donor STR in the blood. In conclusion, our study aids in the understanding of a dismal complication after liver transplant, GVHD. We know that from this study, despite high mortality with GVHD, skin involvement alone portends a more favorable prognosis in this patient group. It's important to identify and work up early rashes, fevers, and cytopenias post-transplant, as this may help in identifying GVHD early. And some examples of possible future directions include a comparison of our 13-patient cohort to a non-GVHD control group, although we need to take this into account in regards to the low incidence of GVHD post-transplant. Some examples in the literature of possible treatment of GVHD. One example is autologous banking of T cells of a recipient in the event of GVHD post-transplant. Another example in terms of prevention are ways to deplete the donor liver's T lymphocytes prior to transplantation. However, these interventions may be helpful if we're able to prevent or predict who will develop GVHD post-transplant. Thank you, and I can take any questions.
This did mention comparing it to other factors.
Mm-hmm.
Do you think that's something you might be able to do before the presentation? Like Shunji might have data on the app, not necessarily the non-GVH, but our overall cohort of patients, what the age discrepancy is.
Okay.
Some of that. I mean, just
That would be helpful to have.
for some people,
Yeah.
for some very good.
Okay.
This is a very uncommon presentation
Yes.
of this bad side of microfilaments.
Mhm.
Right? So have you looked at the literature and tried to find out why this is so common here?
That's a very good question. We don't have, it's our impression that it's not one thing, it's probably multifactorial. This was kind of the reason behind changing our induction protocol. We didn't think it was our induction protocol specifically because, one, that was our induction protocol for many years, and this incidence was higher most recently. We thought maybe a component of this might have been over immunosuppression, so that's why we changed to steroid-only induction. And as Dr. Moonka mentioned, it'll be interesting to see what our incidence is after that. But we're trying to tease out exactly what are those combination of factors, why it's slightly higher here.
So I have just a suggestion.
Yes.
You know, it would be, do you find any common characteristics in the patients that you saw here other than the immunosuppression? Anything common, time of liver disease, cause of liver disease?
So cause of liver disease in the literature is more alcohol and etiology. The donor-recipient age mismatch is thought to be a strong risk factor. Our range is wide, though. Some patients had an 8-year mismatch, some patients had a 40-year mismatch, and they still developed GVHD. HLA matching was thought to be possibly a close factor, but some patients aren't very closely HLA matched, some are. And I think it's limited by the small data, the small amount of patients also. It's only 13 patients, so it's kind of more challenging to find a trend. Yeah. Thank you.
So our next paper will be, Yep. So our next paper will be presented by Dr. Andrew Watson, and the title is The Management of Anastomotic Biliary Strictures After Liver Transplant, Role of Covered Metal Stents.
Thank you very much for the invitation to speak today. The authors and myself have no disclosures. We'll be discussing the management of anastomotic biliary strictures after liver transplant, including the role of covered metal stents. Biliary lesions, including strictures, are the most frequent complication after liver transplantation. Strictures can occur months to years after transplant, although most commonly they present within the first year. There are two types of biliary strictures, non-anastomotic, which we will not focus on today, and anastomotic biliary strictures, which historically have been reported in about 20% of all liver transplant patients. They are typically asymptomatic, presenting really with liver biochemical abnormalities as their only sign or symptom. Anastomotic biliary strictures are typically segmental, focal narrowing at the anastomosis that are felt to result primarily from fibrotic healing, and they are more common than their non-anastomotic counterparts. This table illustrates known risk factors for the development of anastomotic biliary strictures in deceased donor liver transplants, living donor liver transplants, and both deceased and living donor liver transplants. Endoscopic interventions have become first-line therapy for anastomotic biliary strictures. The standard of care includes a biliary sphincterotomy, typically balloon dilation, followed by placement of multiple plastic stents in parallel. These procedures are repeated at 3-month intervals until resolution of the stricture occurs. Historically, the data reports an 80 to 90% efficacy for the treatment of anastomotic biliary strictures with endoscopic therapy. Although up to 20% can recur, with retreatment, it's been reported that 90 to 100% will resolve with endoscopic therapy. Although multiple plastic stents in parallel have been the standard of care, fully covered self-expandable metal biliary stents are increasingly being utilized for this indication. Now we will review one of the largest retrospective data sets regarding the management of anastomotic biliary strictures in liver transplant patients. We reviewed all ERCPs performed between January 2011 and August 2017 in liver transplant patients at our center. 151 patients were identified who had received a liver transplant followed by an ERCP. Out of those patients, 115 were found to have anastomotic strictures out of a total of 666 total liver transplants during that time, for 17% incidence of anastomotic strictures in our liver transplant patients, which is comparable to the historical data. ERCP with initial stent placement was successful in 112 out of these 115 patients. 4 of these patients expired prior to their repeat ERCP, so they were excluded from our data analysis. Therefore, 108 patients remained eligible for our analysis. This table illustrates the basic demographics of our cohort. As you can see, the average age at time of transplant was 56 years. The majority of our patients were male. The most common indication for transplant was hepatitis C. Only 6 of the 108 patients received a DCD liver, or donation after cardiac death. None of our patients were living donor liver transplant recipients. Strictures occurred within 83 days on average of liver transplant. An average of 2.7 ERCPs were needed for either resolution or failure of the stricture. The treatment duration was on average 103 days, and we had a long follow-up of 1,226 days for our data set. So strictures resolved initially with multiple plastic stents in 88% of the patients, or 95 out of these 108 cases. 13% had initial treatment failure. Of these 13 patients, 10 received a covered metal stent for salvage therapy. 9 of those 10 patients achieved stricture resolution. 4 patients required surgical revision for treatment of their stricture. None of our patients received a covered metal stent as index therapy for their anastomotic biliary stricture in this cohort. 12 of the 95 patients with initial success had recurrence during the follow-up period. Of those 12 patients, 5 received a covered metal stent with resolution, 5 underwent repeat multiple plastic stent placement with resolution, and 2 ultimately required surgery for resolution of their stricture. Migration occurred in 4 of the 15 patients who received a covered metal stent during our study period. All 4 of those patients received repeat metal stent placement with resolution of their stricture. Of note, there were no deaths, cases of severe pancreatitis, or other significant complications secondary to ERCP during our study period. In conclusion, our review supports the ongoing use of endoscopic biliary stent placement for the management of anastomotic biliary strictures in liver transplant patients. Resolution can be attained by either multiple plastic stents in parallel or covered self-expandable metal biliary stents. Covered stents are excellent options for refractory or recurrent cases of anastomotic stricturing with success rates of 90 and 100% respectively. Of note, we did warrant we did experience a high stent migration risk, and vigilance to this complication is warranted. Thank you.
Your next presentation, when you say multiple plastic stents placed in parallel, about how many you see, or is there a range that you have of whether some have 2, 4, or 5?
Yeah, so in our cohort, our data set, the average stent placed at the index ERCP was typically 1. Occasionally 2 were placed. What's felt historically and according to the experts is to try to place as many at the index stent as possible. Some challenges include how close to time of transplant these strictures develop and ensuring no disruption of the anastomosis. So typically the endoscopist will start with 1 plastic stent, and then on serial ERCPs we'll try to place subsequent or more stents to allow for stricture remodeling and further caliber change and dilation. So in our center, typically 1 stent and then several stents after that. I think the most stents that we had in our series was 6 at one time, but the majority resolved with 1 or 2 stents at one time. But we do have data, I excluded it from our presentation about the average diameter of the multiple plastic stents in parallel. I felt it might be a little much, but the majority are 1 or 2.
That was very nice presentation. In your results section, you showed that you could know biliary analyses or anastomotic analyses living donor liver transplants. How many living donor liver transplants do you guys do?
So I don't have the data from how many living donor liver transplants we did since 2011. My understanding was we do, I think it's 20 or 30 living donors a year currently, but less than that? 8 to 10, sorry. But I will get that data for the conference so I know what I'm talking about. Yes.
You mentioned being vigilant about migration. I guess my thought is that people would be more inclined to do this if it wasn't for that risk or even concern early on to put a metal stent in. What could you do to kind of be vigilant about that migration risk?
Yeah, so data as well as expert opinion supports using plastic stents inside of the covered metal stent to decrease migration risk. So place the covered metal stent and then placed a double pigtail plastic stent within the covered metal stent. It's been shown to reduce proximal as well as distal migration of the covered stents. One of the challenges in this group of patients is that works better in patients with very dilated bile ducts to allow the internal pigtail to curl and stay in place. If there isn't significant biliary dilation, it's a little more challenging, but it's typically able to be successful.
Thank you. Our final paper is going to be presented by Dr. Lucy Chow, and her paper is entitled Delayed Kidney Transplantation and Combined Liver Kidney Transplantation, a Validation Analysis by the UNOS Registry.
You can just use the arrow keys.
Sounds
to
good.
navigate.
All right, thank you. Good afternoon. My name is Lucy Chow. Today we're going to talk about a validation of delayed kidney transplantation in combined liver kidney transplantation using the UNOS registry. I have no disclosures. Combined liver kidney transplantation, as we know, is the definitive treatment for those suffering from end-stage liver as well as kidney failure. However, due to a paucity of available liver as well as kidney organs available for transplantation, we want to make sure we optimize outcomes for all our patients receiving a donated organ. So a recent study by Exer and colleagues showed that if you provide a kidney transplantation delayed for those who are offered combined liver kidney transplant, that there is a potential efficacy in that. And what they did in their study is they provide the initial liver transplant. They allow the body to rest for 24 or more hours after the initial liver transplant, and then they provide a subsequent kidney transplant that is delayed. And by doing this, they were able to show that these patients had improved 6 and 12 months GFR post-transplant, as well as reduced rates of delayed graft function after the transplant, compared to conventional combined liver kidney transplant, where both organs are placed concurrently. And this was done in a single center study with about 130 patients, and it has not yet been validated using a larger UNOS registry. And that leads to the purpose or objectives of this study, which is to validate whether or not delayed kidney transplantation for those who are offered the combined liver kidney transplant is indeed an efficacious method. We want to look at 1-year patient liver and kidney survival, the incidence of delayed graft function after transplant, as well as post-transplant estimated DGFR at 3, 6, and 9 months. To do this, we fitted various multivariable models using patient and donor factors listed below, and we defined delayed graft function as the requirement to return to dialysis within 7 days after transplant. Data from this study was taken from the UNOS registry from January 2003 to July 2018, with minimum of 1-year follow-up, and we included all adult liver kidney transplant waitlist registrations in this study. How we defined a delayed combined liver kidney transplant group is by taking the cold ischemic time difference between the kidney transplant and the liver transplant. So if the difference in your cold ischemic time was more than 24 hours, we considered you to have had a delayed kidney transplant. And if the cold ischemic time difference was less than 6 hours, we considered you to have had a conventional combined liver kidney transplant. This table shows the baseline characteristics of this study, waitlist and transplant characteristics. Here we show the cold ischemic time difference table. And you can see that 4,460 individuals had a cold ischemic time difference of less than 6 hours, so that would be our conventional combined liver kidney transplant group. And 915 individuals had a cold ischemic time difference of more than 24 hours, so that is our delayed kidney transplant group. In terms of 1-year patient survival, we show that in multivariable analysis that delayed kidney transplantation is associated with significantly worse patient survival for 1 year. And when you stratified by MELD scores, those with MELD greater than 35 also had significantly worse patient survival at 1 year. Looking at 1-year liver graft survival, similar trends. Delayed kidney transplantation is associated with significantly worse 1-year liver survival, stratified by MELD scores. If you had MELD greater than 35, that was also associated with significantly worse liver survival. Same story for kidney transplant survival as well. This is death-censored graft survival. All MELD scores, significantly worse kidney survival at 1 year. And when stratified by MELD, those with MELD greater than 35 also had significantly worse outcomes. Looking at delayed graft function, the incidence of delayed graft function in this cohort is roughly 21%. Here we show that regardless of your MELD score, delayed kidney transplantation was associated with significant protection from the development of delayed graft function after transplant. Finally, looking at estimated GFR after transplant at 3, 6, and 9 months, there was no significant difference between getting a delayed kidney transplant compared to conventional means. And the mean GFR was 65 for 3 months, 64 for 6 months, and 63 at 9 months. So in conclusion, we showed that delayed kidney transplantation for those who are offered combined liver kidney transplantation was associated with worse 1-year patient liver and kidney survival compared to traditional means, and also specifically within those who have MELD scores greater than 35. Delayed kidney transplantation was associated with protective against the development of DGF across all MELD scores, and there was no significant difference in estimated GFR between delayed kidney transplantation. compared to conventional simultaneous transplantation. So thank you to my mentors, and I would be happy to take any questions at this point. Hey, yeah?
Did you consider doing any type of like multivariate models where you control for just cold ischemia time of the kidney itself? Because the delayed group is automatically going to have a kidney that has at least 24 hours cold ischemia time. So did you look at that and see any differences between the groups?
Yeah, cold ischemic time is part of the model.
Okay.
Can you get closer to the microphone? Just keep that in mind when you're giving your talk.
Sure.
And just a comment, I will make the font a little bigger.
Sure, got it.
Depending on the room that you are. So I'm surprised that you didn't find any correlation of the EGFR at 3, 6, 9, and 12. Since those have pretty good correlation with graft survival in kidneys. And you didn't find anything between the delayed kidney and liver versus the standard, right? Do you know why these transplants were lost to, the kidney transplant?
What they were lost to,
What was the cause of graft loss?
for most of them. For
kidney grafts, in both groups, do you know what was the cause?
so I don't have that data right here, but I can update it and send it to you. Yeah.
So somebody's going to mention that one concern is that in the patients who had delayed implantation of the kidney, that the reason for the delay was that there was a problem with the liver transplant. And that's why your survival was worse. Is there some way you can control for that?
So we controlled for as many pre-transplant factors as we can. As you know, the UNOS registry doesn't have perioperative data, like for example, blood loss requirement for pressors. So that is a limitation of the study. We're using registry data. So it's hard to say whether or not all of those who received the delayed transplant had, poor surgical outcomes.
It'd be good to see also if they were pumped, if they were pumped.
Yeah, I do have that data. I don't show it here.
Any other questions?
Thank you. Thank you. Thanks, everybody. I think this concludes our presentations. Have a great day.